Good evening everyone. Thank you the organizer for giving me opportunity to present my topic. I will be talking on the radiation in the xerostomia. How much have we conquered? As we all know, radiation is an important part for management of a head neck squamous cell carcinoma. Local control is directly related to the total dose which can be safely delivered. Radiation for head neck cancers is challenging due to proximity of many critical normal tissues like spinal cord, brainstem, pituitary and the parotid glands. It is associated with significant death toxicities like xerostomia, dental caries, hearing loss, neck fibrosis, in rarely the myelitis and the osteoid necrosis. All these toxicity limit the dose of radiation which can be delivered, which results in reduction in the local control rates. Saliva is a clear, usually alkaline, viscous secretion from three major salivary glands: parotid, mandibular and the sublingual glands. The average daily flow is 1 to 1.5 liters. It is critical for the preservation and the maintenance of oral health. It is needed to moisten the mucous membrane of the upper aerodigestive tract. It facilitates the speech and the control the bacterial flora of the mouth. It also supplies the enzymes for preparing the food for digestion. It is needed for remineralization and maintaining the integrity of the oral mucosa. Radiation-induced xerostomia can be defined as the post-RT changes in the serous secretory cells, resulting in the reduction in the salivary output and increased viscosity of the saliva. The earliest complaint is the thick or sticky saliva. The xerostomia can be acute, which occurs during the radiation and within the 90 days post completion of the radiation, and the late xerostomia, which occurs after the 90 days, is likely due to the fibrosis of the salivary glands. The xerostomia results in reduction in the salivary flow, salivary buffering capacity and the salivary amylase activity. It also causes a significant alteration in the concentration of the total protein and the other constituents of the saliva. Xerostomia can be graded with the RTOG grading system, grade 1 to grade 4. Again, xerostomia can be graded based on the changes in the diet pattern and the fluid requirement, while the chronic xerostomia is graded based on the response to the stimulation. What are the factors which affects the xerostomia? The parotid gland dose volume effects are the widely studied factor affecting the xerostomia. There can be a potential compensation by the less radiated gland tissue. There also occurs a functional recovery which occurs in the gland function, or which occurs over the period of time, and the pre-RT nutrition status determines the xerostomia. It was first postulated in 2003 that for maintaining a stimulated salivary function in the parotid gland, the mean dose should not exceed 26 gray, while to maintain the unstimulated salivary flow, the mean dose should not exceed the 24 gray. To deliver the radiation, the newer techniques like intensity modulated radiotherapy and the volumetric arc therapy are very useful. It is a highly precise and conformal radiation techniques. It results in the reduction in the acute and late toxicity, which ultimately results in the better quality of life. It increases the compliance and tolerance to the treatment, and the wide use of IMRT and VMAT has been the game changer for the head neck radiotherapy, especially for the xerostomia. Coming to the evidence which favors the use of IMRT for all patients. In Nutting et al. In 2011 presented the first trial, which was a phase 3 randomized multicentric trial directly comparing IMRT with a conventional RT. The 47 patients were randomized in each arm. They were assessed by the Landstoma scale. There is a median follow-up of 44 months. At 1 year, the 73 out of 82 patients had xerostomia. However, the grade 2 or worse xerostomia was significantly more in the conventional RT arm as compared to IMRT arm. This difference was maintained at 24 months also, and there was a significant recovery of salivary secretions and the patient specific quality of life outcomes in IMRT. This chart shows the difference in the figure. This was followed by a 2 randomized trial from Tata Hospital. In the first trial, Dr. Sharvani ma'am reported outcomes of 59 patients randomized between IMRT and 3D CRT. At the median follow-up, the incidence of grade 2 or worse xerostomia at 8 weeks was significantly lower with IMRT. This was maintained in the subsequent long-term follow-up. Long-term weight loss was significantly higher in 3D CRT. The disease-related outcomes like local control, disease-free survival and overall survival seem similar. This chart shows that more than grade 2 xerostomia was virtually for none of the patients at 24 months. The second trial, which reported by Dr. Teshpan, this was reported in 2020 with the long-term outcomes. Again, the 60 patients were randomized between 3D CRT and IMRT. At the median follow-up of 140 months, the 10-year local control PFS and OS was 73%, 45% and 50%. There was no significant difference between 3D CRT and IMRT in terms of outcomes. However, IMRT was having a significantly lesser grade 2 or more xerostomia and subcutaneous fibrosis at all point of time. This chart shows the results for the grade 2 or more xerostomia, which is significantly less for IMRT. Coming to the other salivary glands, the submandibular gland is responsible for visual secretion of the saliva. The sparing of submandibular gland is important in prevention of xerostomia. Sparing can be achieved by surgically transferring gland out of the radiation portal or reducing the radiation dose. Indications for submandibular gland sparing is the squamous cell carcinoma involving the posterior part of the oral cavity, nasopharynx, oropharynx, hypopharynx with a contralateral negative nodes. Coming to the evidence for the sparing, Zoe et al. Reported outcomes with nasopharyngeal carcinoma, where they try to spare the submandibular glands. They compared the outcomes with the submandibular gland spared and unspared group. The dose of the submandibular gland was significantly less in the optimized plants. The unstimulated salivary flow rate and stimulated salivary flow rates were significantly lower in unspared group as compared to the spared group. They concluded saying that the sparing of submandibular gland is of a great clinical importance in prevention of acute xerostomia. Coming to the some newer advances, rather than sparing a parotid gland, is there any added benefit of sparing a parotid ducts also? In this study by David et al., they tried to contour the parotid ducts using the MRI xylography. Then these contours were fused with a planning CT scan and they optimized to reduce the dose to this parotid duct. In this study, they included 26 patients of oropharynx. The outcomes were reported at 6 months and 12 months, and the outcomes were compared with the historical cohort treated with only a parotid sparing IMRT. To that result, the moderate xerostomia was significantly less in the patients in which a parotid duct's dose was reduced with IMRT as compared to the historical cohort. The same benefit was maintained at the 12 months also. The mean parotid duct dose significantly correlated with the severity of the xerostomia. Coming to the last part of my talk, is there any diurnal variation in xerostomia post radiotherapy? In our department, as a part of thesis for a DNB student, we tried to assess the same in 100 consecutive patients who were coming for follow-up post completion of the radiotherapy. The majority of patients were oral cavity patients. The 71 patients had received a post-op adjuvant radiotherapy, while the remaining had received a definitive radiotherapy. 58 patients had treated with a VBAT and the remaining with CRT, and 58 patients were evaluated within 1 month, 1 year post radiotherapy. We had used a GIRX questionnaire, which is a validated 14-question questionnaire for assessment of the diurnal variation, and these were the responses which we recorded. Coming to the results, the moderate to severe dry mouth was seen in 35 patients during the daytime as compared to 22 patients during the night time, which was statistically significant. Similarly, need to drink more water and the sticky saliva was significantly high during the daytime as compared to the night time. The factors which were influencing the xerostomia were VMAT technique, time gap of more than 1 year post completion, and the lower contralateral parotid and the submandibular dose. However, the concurrent chemotherapy intent of treatment, either definitive or adjuvant or tobacco use, had no impact on the outcomes. Coming to conclude, the xerostomia is a significant lead toxicity. There is a linear variation in xerostomia, with daytime xerostomia being more common than the nighttime. Use of IMRT or VMAT technique with sparing of contralateral parotid and submandibular dose is advocated for all cases. This is needed for effective rehabilitation and improvement in the survivorship for head neck cancer patients. However, cost remains an important factor for treatment of all patients with IMRT and VMAT. Thank you.